As the title suggests, this project was focused on language disparities in healthcare. Let's see. Throughout the United States, and indeed worldwide, healthcare professionals face barriers on a daily basis. One significant barrier faced is created when a provider and a client speak different languages. Most healthcare systems have available resources to usurp this problem through the use of professional interpreters. However, many healthcare workers report that the use of professional interpreter systems is both cumbersome, time-consuming, and not always possible. Other times, situations may only merit one-way communications, such as direction from a provider to a patient, a short yes or no question, or something similar. These situations create a gap in resources between what is available and what is needed in most cases. This innovation proposal seeks to address the issue created by this gap in resources by allowing providers to communicate with patients when professional interpreter services are not readily available, resulting in better care and outcomes for these patients. At 18.7%, nearly 1 in 5 Americans speak a primary language other than English. At least half of these people have very limited or no ability to speak or understand English. Other estimates have the total of limited English proficiency patients at about 16%. Language disparities between healthcare provider and client is a significant cause of healthcare disparities, as patients who have limited English proficiency or young patients with parents who experience this are more likely to experience negative outcomes related to healthcare. Lack of accurate communication causes a failure to communicate risk and importance of treatment, which can often result in costs related to non-compliance, including readmission, additional treatment, and treatment with preventable deterioration. This is not only a burden on the patient, but it's a burden on the taxpayers who support these patients. In recent years, many healthcare professionals have sought to use other available tools to solve problems created by incongruent spoken languages between provider and patients. We will discuss these strategies in the upcoming sections. One solution these healthcare providers have tried has been to use Google Translate, a commonly accessed application which uses language translation protocols and a database to translate from one language to another. Unfortunately, multiple studies show this is not an appropriate solution. In one study, 10 common medical phrases were translated from English into 26 other languages from around the globe. These translations were sent to bilingual professionals and translated back to English in return. Of the returned messages, only 57% were translated correctly. Another study performed on the viability for Google Translate for English to Mandarin and vice versa was a little more promising, showing 72 and 67% accurate translations respectively. However, this is still far from safe. Another solution to the problem that many providers use are ad hoc interpreters, which are bilingual bystanders, family members, or other staff members. This method is also unsafe, as these interpreters may be untrained in medical terminology, or in some cases still be learning the mastery of 2 languages. Such is the case with children. Many cases of healthcare disparities have occurred because doctors have relied on small children to translate, and many times they don't know how to translate correctly whatsoever, especially when the doctor uses words they don't know. Reliance on ad hoc interpreters has led to many unavoidable disasters and negative outcomes of patients in the past. Another significant case I can recall is an 18-year-old patient. He stumbled into his girlfriend's home and he said, "Intoxicado," and passed out. This is what the girlfriend told EMT workers when they arrived. Unfortunately, the EMT workers assumed that intoxicado means intoxicated, and this was the report that went on with the emergency room and further treatment in the hospital. This patient was unconscious for 36 hours before any other treatment was actually considered, and when they did an imaging workup of his brain, they discovered that he had a subdural hematoma with brainstem compression. This patient unfortunately did not live much longer, and he was a quadriplegic for the rest of his life. This is a case that could have been definitely avoided had the professional interpreter system been used, and it's a perfect example of why that's the most viable option. The family in this case won $71 million in the lawsuit. As I have established here, there is a gap in the needs for translators. But before picking a strategy to assist with the existing gap, it is vital that providers understand any currently existing strategy cannot and should not replace professional interpreter services. The mild nuances in many dialects that exist, not to mention advanced medical terminology, provides many opportunities for mistranslation or improperly emphasized risk when providing education, and this can be disastrous. Whenever possible, especially when the conversation will be two-way or provide education, professional interpreter services should be used. For this project, I decided to collaborate with two Bachelors of Nursing Science leadership students who had approached me and asked me to mentor them. Although I did all of the work related to the mobile application CanopySpeak, which will I discuss soon, they took their part by researching and providing education on existing interpreter services and equipment within the hospital. Part of my innovation required a reinforcement of using those tools we have before introducing new tools to fill the practice gaps discussed previously, as I do want staff to use professional interpreters whenever possible and only my new strategy when not. Good leadership consists of showing average people how to do the work of superior people. John D. Rockefeller. I'm not saying that inherently people are better than others, but however, as a leader, I would like to bring my followers to their highest potential, making them superior people. The mobile app I have chosen is CanopySpeak. I chose CanopySpeak for two primary reasons. The first is that CanopySpeak provides medically accurate translations for many phrases, yes or no questions, and commands that might be necessary during the treatment of a limited English proficiency patient. This fills the gap I discussed previously where professional interpreter is impractical but communication with the patient is necessary, and helps to avoid less effective methods such as nonverbal communication and ad hoc interpreters. This screen shows what CanopySpeak appears like, and the many different language options and phrases that are available. That said, the second reason I chose CanopySpeak is that the application integrates a healthcare worker's professional translator in a way that direct didactic communication is always available if necessary by the press of a button. As stated previously, this remains the safest and most effective method to translate care and should be used whenever possible. An example when you could use this is if perhaps you're just using the application to explain a procedure and then the patient asks you a question about the procedure and wants something explained before you begin. It may just be a simple procedure and you don't know how to answer that question, so you just press the button on the bottom and you're hooked up with video chat and you've got a translator available. There are many theories on how innovation becomes successful. For the purposes of this project, I use the concepts outlined by Frans Johansson in the Medicae effect. According to Frans Johansson, writer of the Medicae effect, innovation is achieved through a process of observation and integration at a metaphorical intersection between different points of view. Wow, that was a mouthful. Basically, what the author was trying to say is that different perceptions from fields seemingly unrelated can play a large role in creating effective change. Johansson outlines three specific characteristics, or principles, if you will, of innovation. The first is that innovative ideas should be unique or new. The second is that they must be valuable. And the third is that they must culminate in actual change. They must be realized. Basically, it can't be just you that finds them valuable. Other people need to find them valuable and use them. Considering the three characteristics of innovation, I now compare to my project. The focused goal of my project is to improve care for patients with limited English proficiency by increasing the available tools to the providers, specifically with the intention to fill gaps left by the professional interpreter system. The innovation I am attempting to create is new and unique because it is the first and only widely acceptable mobile-based translation app with a focus on medical accuracy. It is valuable as it can help providers to communicate with their patients. However, only time will tell if it will be realized. A limited qualitative survey performed at Kaweah Delta Hospital shows that staff nurses and aides find the application accurate and valuable. However, as John Hanson stated, innovation is not truly realized unless society, in this case healthcare workers and patients as a whole, deems the innovation useful. Here you will find the references for this project. If you have any questions, feel free to contact me via the Blackboard messaging board, or if you want to, you can email me at mnhilvers, H-I-L-V as in Victor, E-R-S, @hotmail.com. Thank you.